A very good evening to everyone. Myself, Dr. Amithash. I'm a consultant pulmonologist in Service Superspecialty Hospital, Shivamogga in Karnataka. Today, in this CCI webinar, supposedly the last webinar of this year, we are going to discuss about smoking cessation, a New Year resolution to keep. The Church Council of India started way back in 2014 as a small group of like-minded pulmonary friends who wanted to keep in touch professionally and academically. Over a period of time, under the leadership of visionary founder trustees of Panelists Krishna sir and Dr. Narendra Pradeepa sir, today CCI has grown beyond leaps and bounds as a big family of pulmonologists, from resident doctors to stalwarts of pulmonology being its active life members. As an organization with more than 200 life members, more than 2,500 active WhatsApp members, spread across 10 WhatsApp groups, CCI has been exemplary in its activities with maintaining decorum, strictly confined to academic and patient care, where one can get opinion from subject experts very easily. Academic and professional workshops across national international forum getting endorsed by CCI, periodical CCI webinars, and recently concluded conference in Chennai, getting acclaimed by delegates from residents to subject experts, speaks itself about success of CCI. I feel myself very fortunate to be a part of this last webinar of CCI of this year 2021. And as the title itself reads, a new year resolution to keep the smoking cessation. Though smoking cessation is the most debated topic, if not properly coordinated, it has very low success rate, as it involves physiological, pathological, and psychological issues interacting and intervening between them. Taking its importance, the WHO is observing World No Tobacco Day every year on May 31st, with selected themes of observation. The theme of 2020 was the tobacco industry being exposed, the secret is out. The main theme was protecting the youth from tobacco industry. And various studies showed like 2021 being an era of pandemic, there are a lot of people who are ready to quit from smoking. So 2021, the theme was changed to commit to quit, quitters are winners. So this is a vital issue to discuss. So today we have with us to discuss on this issue, eminent faculty as panelists, and our moderator being none other than senior pulmonologist from Delhi, Dr. Rakesh Chawla sir, who is currently the chairman and senior consultant of pulmonology, critical care and sleep medicine at Service Superspecialty Hospital, New Delhi. He is also a consultant at Jaipur Golden Hospital and Rajiv Gandhi Cancer Institute, New Delhi. I welcome you, sir. We have also one more senior faculty from the East, Dr. Sudarsan Pothal sir, Professor, Department of Respiratory Medicine, Sri Jagannath Medical College, Puri, Odisha. I welcome you, sir. We also know tobacco addiction has a lot of psychological issues to be taken care of. So we have amongst us Dr. C. Manjula ma'am. She is a clinical psychologist at Apollo Hospital, Jubilee, Hyderabad. I welcome you, ma'am. And I myself will be joining as a fourth and most panelist in this discussion. I welcome all the panelists and all the attendees to this webinar. I will now hand over the mic to moderator Dr. Rakesh Chawla sir to take the proceedings further. Thank you.
Thank you for the kind introduction, Dr. Amithash. I am very happy to be part of the family of CCI, meeting the people across the country. Dr. Sudarsan sir from Puri, Odisha, Amithash from Bangalore, Dr. Manjula Rao, a clinical psychologist. I think she is a great help in helping to get the smoking cessation done. Before I start my talk, I am thankful to the stalwarts of CCI, Krishna Bhai, Dr. Amutha. They have done a wonderful show of South Zone Conference. I was lucky to be part of it. You can see the scientific deliberations. You can see how Krishna Bhai is being honored by Amutha sir. Close discussions, a beautiful celebrations. You missed if you did not see the CCI celebrations It was all a surprise and a different experience. I had been opportunity to be on the dais with Ravi Bhai, with Krishna Bhai, with Vijay, and you can see after the inauguration, there was a celebration of the happy birthday of Kirat. And after the scientific deliberations in the night, they had a beautiful enjoyment. So, a wholesome feast, a wholesome conference, which I had a chance with so much of personal connection. And this is what is CCI. So, thank you, Krishna Bhai. Thank you, Vijay. Thank you, Ravi, for involving me for this webinar. The theme is let us resolve that we will not smoke. The doctors who are smokers at least should resolve and become a role model of stopping the smoke and motivating their patients to help them smoking to stop. How we are going to discuss this issue, it is the presentation in my slides. The average smoker takes 10 puffs per cigarette. If you smoke a pack of cigarettes a day, this is about 200 puffs. It takes 7.5 minutes to finish the cigarette, and there are more than 5,000 carcinogens in the smoke which you are inhaling inside. The butt which you are keeping in mouth, the temperature is 37.5. And will you believe the burning and the temperature is 960 Fahrenheit. You see the tobacco burning at that temperature, how many carcinogens are generated and which go with each puff of smoke. The moment nicotine reaches the smoker's brain within 7 seconds and twice as fast as syringe full of heroin injected into the vein. This is the effect of nicotine within seconds on your brain. Once it enters the brain, it begins to mimic the brain's most powerful chemical messengers. The result is enhanced pleasure, decreased anxiety, and state of alert relaxation. Because of this positive reinforcement, many times a day, smoking becomes a part of every aspect of smoker's life. Why do we smoke? Nicotine is the only known psychoactive ingredient in tobacco smoke. Addicted smokers smoke for one principal reason: to get their accustomed dose of nicotine. When you stop smoking, you will likely experience unpleasant side effects. Research shows that nicotine provides a variety of desirable psychological effects. Most smokers say that smoking helps them with concentration, reduces tensions, helps them relax, decreases feeling of distress, helps keep their weight down, and that is the reason it is very hard to quit. It helps you to socialize, it helps them to make friends. So because smokers have got their different class, so they will choose each other very, very easily. Smoking is not just a habit, it is an addiction. Nicotine in a cigarette is a powerful addictive drug that makes smokers feel good. Each time you smoke, the positive biological effects of nicotine add to all the other positive rewards of smoking. Nicotine affects almost every organ system in the body. Smoking endangers health of the environment and all living beings. 948,327 pounds of toxic chemicals were released from US tobacco facilities in 2018. Our world is not an ashtray. Toxic chemicals contaminate our water, ground soil, and harm our wildlife, aquatic life, and plants. And 766,571 metric tons of cigarette butts were in the environment, and they are released every time in the year, and they are not destructible. Smoking kills. We know it kills. Raj Kapoor, greatest showman from Bollywood, died of COPD secondary to the smoking. Walt Disney, famous cartoonist, died of lung cancer. George Harrison, famous Beatles, died of lung cancer. Dean Martin died of lung cancer. John Wayne again died of lung cancer. Promoters, our celebrities, who are the examples to our younger generation. You can see when they smoke on screen, and the girls who smoke on screen, the statistics show that 52% of children have their first puff of a cigarette because of the movie celebrities. Smoking kills more people each year than AIDS, fire, car accidents, murders, suicides, alcohol, and other drugs combined. Worldwide, 100 million died of smoking in the 20th century. Currently, tobacco use causes nearly 6 million deaths per year. By 2030, there will be more than 8 million deaths every year. During 21st century, 1 billion deaths are likely to occur secondary to the smoke. Nearly 1 million people in India are dying from smoking every year. 2740 people every day, and about 1.9 Indian every minute is dying secondary to smoke. Any form, tobacco in any form is used 34.6% of population, out of which 47.9 are men and 20.3% are women. Smokers are 14% who smoke tobacco as a smoke. So 24% are the men and 3% are women who are smokers. In India, 5 million children under the age of 15 are addicted to tobacco. Secondhand smoke is as harmful as much as the active smoking. Secondhand smoke is a significant problem in India, both indoor and outdoor. 70 to 80% of males regularly smoked at home, and 3 of 10 adults in indoor are exposed to secondhand smoke. Secondhand smoke exposure also helps generate future smokers. Third hand smoke. What is this terminology? Is a tobacco toxins that persist in indoor environment even after the most of the airborne components of smoke have cleared. Children are at increased risk when exposed to these toxins. It causes significant damage to DNA in the human cells. What are risks from smoking? It can damage every part of the body. Leads to head and neck cancer, lung cancer, leukemia, stomach cancer, kidney, pancreas, colon cancer, bladder cancer, and cervical cancer. Chronic diseases like stroke, blindness, gum infection, aortic rupture, CAD, pneumonias, COPD, hardening of the arteries, reduced fertility, and hip fracture. What are health benefits? Respiratory health benefits of quit smoking are: it reduces the risk of developing COPD. Those with COPD slows the progression of disease, reduces respiratory symptoms, reduces respiratory infections, may benefit asthmatics too, and improve the treatment outcome. And if you see, count it in hours, within 24 hours of quitting, nicotine level in the blood drops to 0. 1 to 12 months, coughing and shortness of the breath decreases. 3 to 6 years, added risk of coronary heart disease drops by half. 10 years, added risk of lung cancer drops by half after 10 to 15 years. Risk of cancer of bladder, esophagus, and kidney diseases decreases. 15 years, the risk of CAD drops close to that of someone who doesn't smoke. 20 years, the risk of cancer of mouth, throat, voice box drops to close to that the non-smokers. So you can see the innumerous benefits. When you stop smoking, you start getting the benefits from the minute you stop smoking. Save others. Quit smoking. Quitting smoking is a single best way to protect family members, co-workers, friends, and others from the health risk associated with breathing the secondhand smoke, and they are your nears and dear ones. Nicotine addiction. Nicotine, as I said, is a powerful mood-altering substance that is extremely toxic and addictive. It takes 7 seconds for nicotine to reach the brain, causes brain to release dopamine. Dopamine gives a false sense of well-being. Soon the body wants more and more of it on a regular basis. This is the beginning of addiction. It's a very difficult task. It's easy said than done. Nicotine addiction has been one of the hardest addictions to break. It is like addiction to the drug as heroin and cocaine. Nicotine content in cigarettes has actually slowly been increased over the years. Quitting is difficult. It is the nicotine addiction that makes it difficult. 68% of adult smokers in United States said that they wanted to quit smoking. More than 50% of these reports making a quit attempt in the past 1 year. Less than 1 in 10 adult smokers succeeded in quitting. 4 of 9 adult smokers who see a health professional do not receive advice to quit. The practitioners, we are so busy that if you forget being pulmonologists, it is rarely that you don't ask the question that do you smoke? But at the same time, after writing a treatment, we need to spend a few minutes with him that he has to stop smoking and how we can help and facilitate his habit to get him de-addicted. What are the predictors of successful smoking cessation? Like if your life partner is not a smoker, fewer previous quit attempts, low daily cigarette consumption, low nicotine dependence, and males are very comfortable when they decide to quit. Symptom withdrawals of nicotine, craving or urge to smoke, irritability, frustration, anger, anxiety, difficulty concentrating, restlessness, depressed mood, insomnia, impaired performance, increased appetite, and weight gain. Believe it, when he is not smoking the cigarette at a time when he is to take the smoke, it's unbelievable in the beginning what happens to the smoker. Interventions for smoking cessation are abrupt quitting and reduction to quit. Behavioral counseling, we have with us today clinical psychologist, pharmacotherapy, nicotine replacement, drugs for pharmacotherapy, electronic cigarettes, and multimodal approach for smoking cessation. Abrupt quitting and reduction to quit. There are evidences that neither reduction to quit nor abrupt quitting intervention results in superior long-term quit when compared with others when you are using a multimodality approach. How? To assist in quitting, pick up a quit day, prepare for it, tell people, clean the house, avoid triggers, keep substitutes, handling the quit day, staying quit is very, very important. So how you pick up a day? Pick a specific day within the next month to quit smoking, not too far, to give yourself a time to prepare. Pick a random date or a day which is important, like your birthday or a holiday or a New Year Eve, which is walking in. The purpose of seminar is to help you stop smoking and make a resolve that you are picking that day to quit. And if 1% of those who are attending webinars and who are the smokers make a resolve to quit, I think job of this seminar is done. Although many smokers believe they would prefer to reduce smoking gradually, recent evidence indicates that abrupt quitting, setting a quit date and sticking to it results in successful long-term quitting. Must prepare for the quit day. You can use nicotine replacement therapies at least week or 2 weeks before. You can use the pharmacological agent like vernaculine or bupivacaine, and you should have a support program, individual, group, or telephone counseling to support your preparation for the quit day. Online tools and apps can be used. List of smoking triggers and habits like smoking, and analyze daily smoking practice when stressed, after a meal, or during work breaks. Whenever you try to see that you are distracted at a time when you are going to pick up a cigarette. Tell people, family and friends that I have a resolve to stop smoking. Please check on me. You can ask them, help plan activities, and be patient with your changes in mood. People who smoke, not to smoke in front and should not offer a cigarette to him. Read the home, car, office, and other places of the cigarette, lighters, matches, and ashtrays. Wash clothing that they may have a lingering smell of the tobacco. Clean upholstered furniture or the curtains. Quit smoking drugs like vernaculine, bupivacaine can be used at least a week before the quit date. Chances of successful quitting with a single medicine is best with varenicline not to be used during pregnancy and breastfeeding, to be used in 18 years and older. Based on some studies, varenicline appears to be more effective than NRT or bupropion. Counseling, very, very important. Meta-analysis of 49 studies. Counseling increased the likelihood of quitting by 40 to 80%. Individuals' counseling is more effective than self-help material. A more intensive counseling is more effective than a less intensive intervention. Be a role model. Doctor play a crucial role. And if you are a smoker, you inside feel guilty when you are asking your patient to stop smoking. Father, if a smoker cannot tell his son, you please stop smoking, while children can help their parents to bring the placards and telling them, Papa, I want to live more with you. Please stop smoking for us. This kind of the emotional connect by the children to the father, I am going to show that anyone who is attached emotionally with the family, with their children, will think of stop smoking. Combining counseling with pharmacotherapy, it helps, and behavioral support increases the smoking cessation success. Pharmacotherapy, we have nicotine replacement, patches, lozenges, oral inhaler, nasal sprays, drugs I have told are available, and you can combine these therapies. Nicotine replacement therapy, as I said, these patches are available of 21 milligram, 14 milligram, 7 milligram. We have been using them since 1992, 93 when I was abroad, and they were available by the Siba Gaigi abroad, made in France. Now our country also is, they are available in our country, and we can use them for helping the patient to decrease the urge of smoke and supply the nicotine through the skin, and the craving will reduce and helps in reducing the withdrawal symptoms. If the smoker has more than 20 cigarettes per day, so 21 milligram is started. If the cigarette is less than 20 cigarettes per day, you can start with 14 milligram, and 7 milligram can be used step down. It is given every week. You are using on a skin, the hairless area, and apply it for 24 hours. The nicotine keeps on supplying through the subcutaneous route, intradermal route, and it definitely helps. It helps for the person to get de-addicted and reduce the smoking. Combination therapy with NRT, systemic and the local, both are very effective when they used in combination. Replacement therapy delivers nicotine more slowly and at lower levels. They are less likely to be associated with addiction when compared to the tobacco products. Another important aspect is the electronic cigarettes or vaping, more fashionable, not safe for smokers or passive smokers. Present status of e-cigarettes is uncertain as to how safe or harmful these are. The chemical present in the vapors consist of propylene glycol, carcinogens, and heavy metals. E-cigarette or vaping leads to the lung injury. An outbreak of electronic cigarettes associated lung injury in 2019 led to the younger generation dozens of deaths and the hundreds of hospitalization. Fruit and mint flavored cartridges based e-cigarettes are banned in the United States. More than 5 million US students are currently e-cigarette users. An alarming rise of vaping related lung illnesses and death has raised many concerns. Some young people are thinking cigarettes may be safer than vaping now. 2021, a recent Cochrane review has shown that electronic cigarettes with nicotine increases the quit rate compared to the electronic cigarettes without nicotine and compared to the nicotine replacement therapy. Some other studies have also shown improved cessation rates among e-cigarette users. Some organizations, advocacy groups, policymakers discourage the use of electronic cigarettes. The US Preventive Service Task Force concludes that evidence on use of e-cigarettes for tobacco smoking cessation in adults is insufficient and the balance of benefit and harms cannot be determined. There are 7 FDA-approved medications: nicotine gum, nicotine patch, nicotine lozenges, nicotine nasal sprays, nicotine inhalers, bupropion, and vernicillin for helping the patient to get de-addicted. Now, very important aspect is a multimodal approach. So, integrated approach appears to be effective to help smokers quit or reduce their smoking, because you have to use the combination therapy to help your patient to get de-addicted. Smoking cessation is a single intervention which offers several health and many other benefits to the person and the society and lets them all lead a healthy life. Do not let the lungs become a garbage bin. Keep them healthy and beautiful. Electronic cigarettes are banned in India. These are the references. And I'm thankful. Before I end the talk, I must thank Professor Katiyar sir also for helping me to have these beautiful slides. Thank you very much, sir. Thank you. Amit, I have stopped sharing. Okay, okay. Now we are now coming on the second part of our webinar after this talk. So I welcome Dr. Manjula Rao, Dr. Amithash, Dr. Sudarsan sir for being part with me to participate in the deliberation and discussion about multimodality approach for cessation of smoking. So to kickstart, I think the ladies are always respected, regarded in our country. I will kickstart with our young clinical psychologist, Dr. Manjula Rao. What makes one smoke and maintain that behavior, what forces it? So I will like Dr. Manjula Rao to kickstart the proceedings.
Thank you, sir. It's wonderful to be a part of this group today, and it's really my privilege. So, congratulations for the wonderful works you all have been doing. So, looking at the question, what makes one smoke and what makes it maintain that behavior? Most of it, Dr. Rakesh has, covered it so well. So I would be just touching purely on the psychological aspects of it. We would not be repeating that. Okay. So before we answer this question, what makes one smoke? In the background, we will have the theory of social learning. Okay. So having a knowledge of this theory will help us understand that smoking is just like any other behavior, which is, learned. So the theory of social learning, which was developed by Albert Bandura, what he said was people learn through imitation. Everything that we learn is through imitation and observation and experience. Okay. So as Dr. Rakesh has said, when children see, like when teenagers or young adults see their parents smoking or their siblings smoking, or when advertisements show the models and heroes smoking as a very cool thing to do, and it's a fashionable thing to do, and also when it is shown as something very safe, then people are encouraged to smoke. So this is purely an imitative behavior. So anything that we imitate goes on to become a habit because of the experience that we have through that behavior. So why people smoke is basically looking at how this behavior starts. In a simple way, this behavior starts because of imitation, because of the learning theory that says that whatever we learn it through imitation. So, which means it's really hard to control unless, we have to ban the whole industry. And somebody was asking this question, why can't it be banned? Yes, it can't be banned because, because we have a huge economic, advantage of it. So that could be one reason that it's really hard to ban it, or it can be used for other purposes also. That's a very simple layman answer for it. So remembering that it is an imitative activity helps us to understand that how this behavior is learned. Well, what makes one maintain that behavior? It depends on two answers that many of the smokers give us. And all the answers they give us can be put into two groups. Number one is the positive group, and number two is the negative group. In positive group, we can say that smoking helps me to, feel energetic. It helps me not to slow down. It gives me that buzz of pleasure because of dopamine and adrenaline that's rushed. And so it gives an opportunity for them to be with their friends. And so it is hard for them to quit smoking. These are the positive responses they give about smoking. The negative responses can be that smoking is there because of the negative emotions I experience, or whenever there's a conflict in my house, I experience loneliness, or whenever there is anxiety, then I experience tension. And as a stress reliever, I smoke. So if you see in both the situations, in positive responses, we saw the person is smoking as a relaxation activity. He has no other relaxation techniques, so he is using smoking as a relaxation technique. And in the second kind of responses, which are negative responses, we see that smoking is used as a coping strategy for distraction. He's distracting himself from his loneliness, or the conflicts, or the stress and tension. So he goes on to smoke. These are the two main clusters of responses we get from individuals when we ask them why they maintain that, why are they sticking on to that smoking behavior. So not only physically, but also there is this mental and emotional component to smoking that makes them feel much dependent on that. That is why they get addicted to it, and it becomes a habit. Like all habits which are mostly unconscious, smoking also becomes an automatic habit. Whenever the need arises, they just go and take a puff. So, in the short manner, we can just say what begins a person to smoke and what makes them maintain that behavior.
Very well. Very nicely explained, Dr. Manjula Rao. I think this perspective of helping stopping cessation as clinicians, we do not do that much of efforts and give that kind of a thinking. Wonderful. I think now we pulmonologists, as having a smoking cessation clinics, we need to have a clinical psychologist with us. So I will now, Dr. Amithash, can you enumerate the clinical health hazards of the smoking?
Good evening, sir. Yeah, as rightly pointed out by you, it's hazardous. It's a health hazard. So I'll just try to make a few points here. I would like to try to modify a question. What not? It causes almost all the organ damage in our body. For the few viewers who are here and who are just picked into smoking, and the people who have just started with the smoking, not gone into that dependence or the withdrawal symptoms, it's worthwhile to know the side effects of nicotine as well. more than knowing the hazardous status or the diseases caused by the smoking. Right from many organs are involved by nicotine. It causes increased blood clotting. It's hypercoagulable state. As we all dealing with the pandemic, we know how much hypercoagulability state can cause damage to lungs and other organs. We all know smokers are wheezers. It causes bronchospasm. It causes gastrointestinal side effects like nausea, dry mouth, dyspepsia, heartburns, joint pains. Again, the cerebrovascular side effects of nicotine, such as lightheadedness, headaches, sleep disturbances, dizziness. It tend to increase the heart rate, increase the blood pressure, sometimes decrease the heart rate, tachycardia. All these are pleasurable side effects, but when it goes for hazardous side effects or the hazardous causes, then it called the health hazards of smoking thing. So, as a clear-cut effect-dose relationship, as shown in many of the studies, such as the Inter-Heart study or worldwide study and the Jackson Heart study, smoking is an independent risk factor, other than all the other lifestyle disorders for atherosclerotic coronary disease, cerebrovascular disease, heart failure, and many other cardiac illness. It has been shown by studies. And we all know, like many of the cancers or the many of the malignancies of our body are directly related to smoking. Maybe it is lung, maybe in the GI tract, maybe in many of the organs of GI tract. In fact, the increase in the incidence of the breast cancer in case of women is directly attributed to smoking. We being a pulmonologist, we also know the causes like COPD, idiopathic pulmonary fibrosis, few of the lung disorders which are specific to smokers like DPLD and RVILD, and few like Langerhans cell histiocytosis, combined pulmonary emphysema with fibrosis. These are directly related to smoking as well. By virtue of damaging the local immunity within the lungs, it can cause increasing infections as well. A newer concept is coming like smokers have a high incidence of insulin resistance and they're prone for diabetes mellitus, osteoporosis, hip fractures, lot of issues with regard to reproductive health such as infertility, peptic ulcer disease. They have a very bad GI tract diseases, periodontal disease. There are a lot of issues with regard to the dental care. Recent guidelines have also been contributing, like the increased incidence of cataract in the early age group may be directly related to smoking, age-related macular degeneration with regard to eyes, and when these smokers get undergo any surgery or something, they have a lot of issues with regard to post-operative complications as well. So, in a nutshell, if you want to tell, if I want to tell the audience or the delegates who are having the habits of smoking or who have the habits of relatives under this menace of smoking, it almost involves all the organs. Okay, so it itself is a direct cause of mortality, and it also contributes to all-cause mortality by causing the disease of all these organs. So it's a day for us to put an end to this menace. Over to you, sir.
So we understand that from the hair on the top to the toe, it can involve any organ. But without doubt, there is a very clear evidence to the pulmonologist. It leads to lung cancer. It's a direct cause of the lung cancer. It's a direct cause of the COPD. And if you happen to see the patient with the end stage COPD, smoking is the single most cause which makes the life miserable. Expectations of the patients are, now we have left smoking, why we are not becoming all right? You ask them how many days you stop smoking, 5 days. But I'm taking your medicine regularly, sir. I'm not getting all right. So the patients, if it happens, and if you make these patient group of end stage COPD and make these smokers in whom you are working, help to smoke, stop the smoking, and you make them, it is going to have a great psychological effect. Now, I come into Sudarsan, sir. What are the health benefits of quitting smoking? What benefits, and when you will start experiencing the benefits when you are stopped the smoking?
Yes, sir. First of all, good evening to everybody, and I very much thankful to the organizer, particularly CCI family. Also, myself also part of the CCI family, giving the opportunity to this platform, being a part of it. Basically, whatever Dr. Amithash has explained whatever the disease, say from hair to toe, can happen due to smoking. Definitely, in nutshell, just in abstract wise or summary wise, I can say, in general, health benefit improve the health status and enhance the quality of life. Reduce the risk of premature death, can add as much as 10 years of life expectancy. Next thing is what about it can reduce the risk of any of the disease, not only the risk of the disease, like say whatever the Dr. Amithash explained, like COPD, lung cancer, say cardiovascular mortality or morbidity, whatever may be. It reduces the risk of happening the disease, not only reduce the risk of happening the disease, but also reduce the progression of the disease. That is important. Next is a benefit of people already diagnosed with coronary disease or COPD. It could be much more benefited. That means a disease progression is quite slow during the after stopping the smoking. As regard to our respiratory benefit is concerned, it reduces the risk of developing COPD. Among the COPD patient, it also slows the progression of COPD, reduce the loss of lung function over time due to the quitting of cigarette. Reduce the respiratory symptoms like say cough, sputum production, and so. It also improves the lung function, reduce the symptoms, and improve the treatment outcome among the asthmatic patient too. As regard to cardiovascular benefit is concerned, it reduce the risk of disease again due to and also death due to cardiovascular disease. Reduce the marker of inflammation like and also hypercoagulability, development of subclinical atherosclerosis, and so and so. How come maybe there are battery of benefit like that, the prevention of cancer. And finally, it is also very much important, particularly the benefit in health of pregnant women and their fetus in babies also. They reduce the most important part also again, they reduce the financial burden that is the smoking place on the people who smoke, as also from towards the healthcare system, toward the society also. There are a battery of benefit, much more benefit during the quit. It's almost all. Over to you, sir. Okay. In addition to whatever we have discussed, particularly it also reduces the risk of atrial fibrillation, cardiac failure, venous thromboembolism, peripheral arterial disease. It also reduce the risk of abdominal aorta aneurysm and so and so. The battery of over to you, sir.
Thank you, Sudarsan sir.
Yes, sir.
There is a question related to your explanation is from Dr. Ramesh Kumar, Haryana, Panchkula, a smoker of 20 years. If he stops smoking, after how much time his risk is equal to the non-smoker? Sudarshan sir.
Yes, sir. Basically, just before answering that question, just I am giving one. Once a person smoker quit the smoke, benefit starts from day itself, after some minute itself. Whatever Dr. Chawla already pointed out in the PowerPoint presentation, benefit starts from minutes to 15 years, so and so. Of course, basically, it may not be theoretically, may not be the duration of quitting. One extra thing I want to highlight here: the age of quitting or the duration of quitting is benefited. I mean to say, more the quit, duration of quit, the more benefit. Earlier the quitter, better you will get the much more benefit. As regard to the duration is concerned, definitely the duration longer, benefit longer. But as for the clinical, as a clinician perspective, it has been seen that more than 40 years quitting is probably equivalent to non-smoker. Over to you, sir.
So thank you very much, sir. As we know, if you stop smoking after 20 years of the smoke, if to come equal to the non-smoker, it may take you 10 to 20 to 15 years to reduce the risk of lung cancer or to reduce the risk of other problems. But definitely, the minute you stop smoking, your heart rate settles. Your things, it's a different feeling, it's a different platform you will be in. So don't think of when you will be equal to the non-smoker. The amount of years you have smoked and enjoyed, you have to wait for that. But believe it, the day you decide to stop smoking, your health benefits start immediately. Now I'm coming to Dr. Manjula. Why it is difficult to quit? Why it is so difficult? Please.
Yes, looking at this question, we have to remember that it is a problem only if the smoker thinks it's a problem. So unless he thinks it's a problem, he cannot take steps to quit. No matter how best our therapy is, how best advice and information that you provide will not help him. It is not the dearth of information. He knows everything, the cons of smoking. It's not his laziness. It's not his wanting to kill himself. He should realize that it's a problem. And that happens very, very rarely. And when that happens, he can quit it just in a moment. It doesn't take much long time for him to quit. But what really keeps him in this and makes it difficult for quitting, there are many reasons for it. If we see, one thing is age. Age has a positive correlation. Younger the age, poorer the quitting. So if the person has started smoking when he was a teenager, in early teenage, then it's going to be very difficult for him because he was emotionally dependent on this activity. It started as a social activity where he was hanging out with his friends and he enjoyed all that. And so for him, smoking has become ingrained and a part of his personality. So he would take it as a normal way of dealing with his problems. So age is one factor. And there are a few studies which say gender also is playing an important role now. They say there are mixed studies, mixed evidence for this, but most of the studies are saying for women, it's going to be difficult to quit smoking. And then the most important thing is personality factors. Personality factors like extraversion, which means being open to experiences, then it's difficult to quit smoking because people having this personality factor are not into one substance like nicotine. They are open to many, to experiencing many substances and many adventures in life. And that's one reason it's hard for them to quit smoking. And then same is the case with people having introversion personality, which means they cannot handle negative emotion. The moment a negative emotion comes, it's intolerable for them. So they go on to smoke. So if they quit smoking, there is ambivalence. They think, how do I manage with this negative emotion? How can I relax? It's hard for me, so I cannot quit. And the most important thing is, apart from age, gender, personality factors, the fourth important thing is the behavior of the person. If there is, oppositional behavior, so like a rebellious act, if this person wants to, convey to the parents that this is a rebellious act, I'm going to do the opposite of what you tell me, because there's a lot of advice giving and high expressed emotion in the family, and he finds solace in this smoking, then it is difficult for him to quit smoking because it has become a repetitive behavior pattern in them, in himself. So these are some of the reasons why people find it very, very hard to quit. But above all, they should find it a problem. Then they come to you for advice and they are at the right stage of, quitting. It works very easy at that stage for them. Over to you, sir.
Manjula, very nicely. The question is from Punjab, Dr. Vijay Pal Singh Sidhu, Punjab, Jalandhar. Government knows cigarette smoking is not good. Doctors know smoking leads to lung cancer. The whole world knows the butts are spoiling the atmosphere. Secondhand smoke, third-hand smoke. Why the other part? Why you are asking me to quit smoke? Why the authorities do not ban the smoke or the nicotine products or the cigarettes, or why they don't put an age limit? You think from another perspective of the government, if there is a will, there is a way. If there are states which can be without liquor, at least normal population who cannot afford the things to buy expensive in black market, they are definitely are to stop drinking. Similarly, why the states, why the government does not stop promoting the nicotine growing lobby and stops availability of these products? This is a discussion over to all to participate. I want Manjula to start what is her opinion about this.
Yes, as said previously, tobacco industry is giving us a huge economy. It will be very interesting if I ask you this question: how many of us are into stock marketing, and how many of us have ITC in our stocks? So, we cannot really do away with it because it is giving us a lot of money. At the same time, we have a responsibility within us. How much can we look at solutions outside us? There is a very important factor in us called the factor of self-efficacy. The ability that I can trust in myself, the notion that I am able to do something. When the responsibility lies within me, I think I'll have a greater choice, greater ability to make a better choice. So, how many things can be avoided? So, right from our childhood, like we are taught, when we cry, parents tell us not to cry. They try to shield us from every harmful thing. And same thing happens here also. Nobody can shield us from harmful things. Everything is in front of us, and it is us who has to make a choice. Because if it is banned or something happens, I think there'll be a huge economy crisis, because we are getting good amount of money from there. And apart from this, it can be used in other products also in a productive way. This is my short answer. Over to you, sir.
Can I pitch in, sir? Hello? Sir, your voice is muted.
Yes, Amithash.
This was the topic, was ma'am rightly pointed out, the theme of 2020 World No Tobacco Day, the protecting youth from the tobacco industry secrets. Various studies were done all over the world, and what they found out to be is, if the product killed around 8 million people all over the world, they will just target a new generation. It's such a thing which has been the secret of tobacco industry all along. So as ma'am was rightly pointing out, it's within us. If because a lot of things we are exposed in childhood and a lot of pleasurable things we are seeing around, so it's always within us to take up the things. So our basic thing, being doctors and being the healthcare workers, is to create awareness, and it's for the person to take up the thing, if not going for smoking habits or not going for any other substance abuse. So the whole point of educating in 2020, the theme of World Health Organization was to create a tobacco-free generation. That was the thing. So it's always within us. We have to take a chance to get rid of the bad habits.
What is your opinion, Sudarsan sir?
Definitely, actually, basically, it needs a policy. It's a debatable issue. But for that, we need a good act. Then only it can be happened. But whatever our previous panelists all agree, 100% agree with them. Over to you, sir.
So I know one hand is an economy, to the tobacco lobby. 3, putting restrictions and making the public blame, doing all kind of advertisement, putting the dangerous photographs on the cigarettes, making the people afraid. But it's an absolutely, it's debate which has to be generated at a national level, why the government doesn't ban the tobacco lobby. We know the answers, but this is not the platform we discuss. There is a question of asking us to discuss COLD, chronic obstructive lung disease, in detail. I am sure it's not the topic today, my dear. It is Uday Vishwanath Chaudhary from Maharashtra, Jalgaon. I think you keep touch with the webinars of CCI. You are going to listen about cold anytime in details. There is another one from Shrish, Bari Dental Clinic at gmail.com from Tamil Nadu, Madurai. Complete cessation can be done. Yes, it can be done. There is a will, there is a way. Now coming to Dr. Amithash, what are the withdrawal symptoms? We have heard how it is difficult, how we can motivate, but why people don't stop smoking, or they leave for a few days, again get back to, then wait for 1 month, then get back to the smoke by one excuse or the other? What are these withdrawal symptoms which force patient to come back to nicotine?
A good question indeed, sir. There are two aspects in this. One is the whatever the definitions as per the DSM criteria of the withdrawal symptoms. One is the patient perspective. So it's like giving a kid whatever the kid wants for a long time and taking back the toy or something from the kid, and the kid starts irritating. It's something in that, like whenever the person is into the smoking habits for few weeks or few months or few years, there is some sort of maladaptive pattern which develops within his brain because of the reinforcing and pleasurable effects of smoking or the nicotine. And whenever the patient is made to withdraw or abruptly stop or reduce the amount of nicotine or the tobacco, whatever he's using, he is into some sort of symptoms. As per the DSM-4 criteria, this could be within 24 hours or within as early as possible. Some 4 or 5 symptoms such as the depression mood, maybe is insomniac, he's showing a lot of anxiety spells or anxiety episodes. He's irritable, he's frustrated, he's having difficulty in concentrating his work, restlessness, he has a decreased heart rate, and he has increased appetite and weight gain. And this list is not exhaustive as per my experience, since I had come across few things I discussed with few of the psychologists. I think ma'am will accept my answers. Patients may vary because they may have some underlying anxiety already before. They may go for more anxiety spells. If they have underlying depression, they may go for more depression. It's all about the psychological things which are presented in a way like they're addicted to smoking. Whenever we talk with them, they're going to these things. So it's one side on a like the theoretical basis, the definition as per the criteria, and the other side the patient perspective always. So they throw within a few days of stopping the nicotine. Sir. Craving is one more important thing. They crave for getting to go for relax.
Very, very nicely enumerated, Dr. Amithash. That is why the people are getting addicted to nicotine and they find it difficulty to leave it. Lohit from Karnataka's Davangiri. Smoking is equally harmful to every individual. Yes, doctor, we agree. The second-hand and the third-hand smoke is equally dangerous to the things. There is a question from Ajay Lanjevar, Maharashtra, Nagpur. Why there is no strict regulation to reduce manufacturing of BD cigarettes in our country? What are we not pressing over effective measures like New Zealand planning to ban selling cigarettes under 14 years? Dr. Ajay, it is beyond our purview of the CCI. CCI as an organization can write and suggest to Government of India, but this is platform which is non-political, and it definitely needs a debate, which we have already discussed this question. Now, sir, what are the important interventions which you will do for helping the patient to stop smoking? Sudarsan, sir.
Yes, sir. Of course, this is the main key question of this today's session. in general, we can divide it in form of either it could be a non-pharmacological or could be a pharmacological. In non-pharmacological, basically starts from quitting without preparation or without external help. We call it is a cold turkey model. Other important non-pharmacological like individual counseling, group counseling, support counseling, behavioral therapy, and so, and some hypnotics also works. About pharmacotherapy, first of all, I would like to tell about the nicotine replacement therapy. Second, about the drug, like two important drugs available in India also, bupropion and varenicline. So in total, in pharmacotherapy, in the pharmacological aspect, we have a few other drugs, but it is not available so. But whatever may be the first line therapy drug is, as regard to drug is concerned, bupropion and varenicline. And the rest part is nicotine replacement therapy. Over to you, sir.
Sir, we have, which we help the patients with non-pharmacological ways and the pharmacological ways. Non-pharmacotherapies, I think clinical psychologist is a great help to us. Then we have the pharmacological nicotine replacement drugs. We have the patches available in the country. We have the chewing gums available in the country. We have bupropion and varenicline available in the country. But the availability of bupropion and varenicline for smoking cessation, I think there are some government restrictions on it, if I am correct on this aspect. But the non-pharmacological way of helping the patient to stop cessation, I think Dr. Manjula Rao is going to help us with trans-theoretical model of change, how it is. So how it works, ma'am, please elaborate to the pulmonologist of the country. For us, this is a new term, to be honestly admitting that we have no idea about this theoretical model. Please enlighten all of us.
Thank you, sir. It is indeed an interesting topic in psychology. They studied the two famous social scientists. One was Dr. Prochaska, and the other one was De Clemente. So they had this question of how people change and why people don't change from their maladaptive behaviors. So what they did was, this study happened across 1980s, and they said, let us find out what keeps people to behave in those bad ways and continue to remain in that. So what they did was, they made small pamphlets, and in the pamphlets it was written, if you are a smoker and don't want to quit, contact us. And they pasted these pamphlets outside the gyms and bars and pubs and colleges. And when the smokers saw that, they were very interested, because usually it is, if you're into smoking and you want to quit, then contact us. But they said, if you don't want to quit, contact us. So they contacted the scientists, the researchers, and the researchers promised them to pay $10 a month for filling up a questionnaire. And the questionnaire was just to find out why people remain in those maladaptive behaviors, or what prompts them to change. And then came this whole theory of trans-theoretical model of change. What they found out was, Prochaska and De Clemente, that when people want to change, they do not change all of a sudden. It happens in few steps. It happens in some process where they make decisions and where they have some, confidence on themselves, and what really mediates all these processes. Today, we'll stick to the changes of the stages of change, not the other two things like process of change and the decision making and all that, because that's not very important in a medical setting. For us to be crisp, we'll look into the stages of change. So when a person, let us take an example of a boy who is in 8th standard. He comes across his friends who are smokers. So they ask him to smoke, but then he might refuse. He would say that he's not used to it, and his parents may not approve of it. Then they may make fun of him. There would be peer pressure, and they would say, like, if you're a boy, come and smoke with us or something. And then that's very challenging for a young boy, and he wants to prove himself. And so he gives in to the peer pressure and he starts smoking. And one day, his parents catch him and they bring him for therapy. Now, do you think this boy is in a condition to change? Does he have the insight? Does he have the motivation to change? Not at all, because this is his newfound uh, pastime, and he is individuating, and he doesn't want to change in any way because he doesn't have the motivation simply. So at least the next 6 months he would not change. So this is a first stage where in simple words it can be said, I do not want to change. Like in our practice, in my chamber, one corner of the room, I have written this, I don't want to change. So whenever a person comes, I just ask them to choose a corner and go and stand there, so that we as therapists know what is their stage of change. So this is called the first stage. It is also called the pre-contemplation stage, the PC stage. Say after that, this boy goes on, he has a good goal to become a doctor or an engineer, and he joins one of those colleges, where there's so much of study, and every week he has an entrance exam. Then he starts thinking now, should I give up my smoking? I'm not able to concentrate properly. Should I give up on these friends? So this is the second stage where he's not ready for change, but he's thinking of change. So the second corner in the room could be, I'm thinking of change. So which means it's a contemplation stage where he's just thinking of the possibility. And then comes the third stage where he is preparing to change. This can be painted as I'm preparing to change, the third corner of the room. And this is called the preparation stage. And what he does here is his Google searches will be full of how can I stop smoking? How to concentrate better, how to get good sleep, how to avoid friends who smoke, or how to be assertive, how to tell assertively that I don't want to smoke, etc. So he's in a stage where he is preparing himself to quit smoking. And at this stage, they usually come to the therapist. They are also searching for online support, for group therapies, etc. So when they are in this stage, there are three characteristics which are the hallmark of this stage. That is, they are willing to listen to you and they are open to experience this new way of quitting smoking, to be absent from smoking. And they're also, they're flexible. All these days they were rigid. They said, we are not going to quit. Now they are thinking, they are a little flexible. So preparation stage, if they come to you, there is no need of motivation interviewing at all. All you have to do is give your advice and the person is ready to go on. So in the preparation stage, you give them some exercises, they follow, give them a pharmacological treatment, they are compliant. And if they stick to this for 6 months, this behavior becomes somewhat permanent and they go on to the maintenance stage. Now, it doesn't mean that they have quit smoking forever, but it means that again, when they fall back to smoking, they know the steps to regain from it, the steps of quitting, and it will be easy for them to quit again. And mostly they don't fall back once they come to the maintenance stage because they have seen the health benefits of it. Now, the motivational interviewing comes into play when they are in the pre-contemplation and contemplation period stage. That is when they are very rigid and they don't want to listen to their parents and they don't want to change. That is when we have to build an insight into them in the little time that is available for the doctors. Now, how this trans-theoretical model of change is useful for us? Because it gives us a lot of information about our patient to know what stage is he in. Is he in the stage where I don't want to change? I am thinking of change. I am preparing to change, or I am changing and I have changed. Okay. So this way it is useful for us. Thank you, sir. Over to you.
Thank you, Manjula. I am getting convinced with every discussion of yours. We pulmonologists run smoking cessation clinics with making a lot of questionnaires, asking the patient to sign and give the answers. But definitely you have to be the part of smoking cessation clinic. If at all it has to be successful, I am getting convinced. There is no doubt about it. There is a question from Meena Hingorani, Maharashtra. Dr. Meena says, what about the hookah parlors? Again, a debatable policy matter of the government, but definitely the younger generation, on the pretext of that these hookahs does not contain nicotine, but anyhow, the chemicals, things are very harmful. At least government can do to ban them. And again, this is a political question. So sorry, I cannot specify this. So thank you, Dr. Manjula. You are absolutely correct. How the motivational way it is done, how you do it in your clinic, making different corners is wonderful. And CCI should be grateful to you to making you a part of this program. How successful is the abrupt smoking, Amithash? Should you promote the abrupt smoking, or it should be the gradual reduction of the cigarettes?
You're putting me into controversy, sir. No. Okay.
I
A
am
good
there.
question
Okay.
indeed. A good question indeed. So I want to be clear to the audience here. The abrupt cessation, the gradual reduction, only after they have been motivated. That's what I want to mean here. So as ma'am was telling in the previous question, when the patient has gone through all this pre-contemplation, contemplation, preparation stage, they're motivated enough. They're ready to quit. Once they're ready to quit, which one is better? That's what the question I feel. So once they're ready to quit, I vote for, and I have discussed with a lot of clinical psychologists, and I think I should discuss with ma'am more in future. She seems to be very much interested in going through these things. So whatever the clinical psychologist, whatever discussed, they also vote for abrupt cessation. What is the rationale or what is the principle behind this? Any of the patients, whenever they're into smoking thing and whenever they're into nicotine dependence and withdrawal symptoms, they are going to go through these withdrawal symptoms whenever they cessation the habit, whenever they go for cessation. So we have to take care of these session habits. So why not quitting them abruptly? Why quitting them over a gradual reduction? That's what the rationale behind that. And there are many schools of thought, and many people may vary with regard to their opinion. And this has been put up into a few of the studies, and few studies which were in the Cochrane database, which I went through today, and some of the meta-analysis. Whenever the abrupt cessation was planned and when the gradual reduction planned, one study in 2018 which showed like they have a comparable rates of reduction. But whenever these are combined with nicotine reduction therapies and whenever they're combined with the anti-craving medicines like bupropion and vernicillin, then abrupt cessation showed a little bit of successful rates in few of the studies. I think I will seek the help of Rakesh Chawla sir in this, and seek the help of other panelists also in this question. I vote for abrupt cessation when the patient is motivated enough to quit and he has fixed his quit date.
Very nice, Amithash. But definitely the scientific evidences say that it should not be an abrupt because the results are not good. Actually, the gradual cessation with the support of the multimodality with clinical psychologist is going to work. I think the whole house agrees for it. There is a question from Asim Mehta, Maharashtra. Doses of bupropion and vernicillin. It is coming, my dear Dr. Asim. Dr. Sudarsan is going to answer you what kind of NRT is available and how we use them, the pharmacotherapy of smoking cessation. So again, Sudarsan sir.
Yes. Basically, the nicotine, the molecule which make the smoker to addiction. That's why nicotine replacement therapy come to the picture. Nicotine replacement therapy either in the form of gum or patch. Gum and patch both are available in India. Other like say inhaler, nasal spray also, but not available in India. But before we plan to give a nicotine replacement therapy, we should assess whether patient is having nicotine addiction or not. Basically, based on some questionnaire like the Hyderabad questionnaire, there is a 6 question. Each question carries some mark. So roughly around say more than 7 answer is likely to be patient on addiction, nicotine addiction. For nicotine addiction people, we should try a nicotine replacement therapy. Before we go put the mechanism or dose of one of the important picture of failure of nicotine replacement therapy is inadequate dose. So next question arises, how could you judge which patient should be given how much amount of nicotine? Basically, nicotine gum available either a form of 2 milligram or 4 milligram, whereas patch available 7 milligram, 14 milligram or 21 milligram, sometimes 24 milligram like that. So gum, advantage of gum versus patch is gum can particularly in acute care, acute setting, in the acute craving situation, gum is the best option. Whereas patch is slowly released form. That means suppose we need to know the say as Dr. Chawla was already explained about some of the point that the number of cigarette per day. If a person smoke more than 20 number of cigarette per day, probably for that group of patient we need 4 milligram of nicotine gum. Whereas the person smoke less than 20 per day, they need roughly around gum of 2 milligram per tablet. A 2 form of tablet available, 2 milligram and 4 milligram. Second thing, we need to know something basic about the cigarette, particularly. Grossly, the average, in an average, one cigarette is contain about 10 to 15 milligram of nicotine. Out of that, 10% are usually absorbed. That means per day, per cigarette is roughly around 1 to 1.5 milligram of nicotine absorbed. That means the ideal dose, again, as I have explained, ideal dose means once we need to know whether smoker smokes more than 20 or less than 20. If more than 20, we will choose 4 milligram of gum. Less than 20, we will choose 2 milligram gum. First, we should start one tablet each 1 to 2 hour interval for first 6 weeks. Subsequently, again one tablet for 2 to 4 hour interval after 6 weeks till 3 weeks. Next 3 weeks. Next, gradually we will decrease again one tablet each 4 to 8 hours for next 3 weeks. The maximum per day a person can take roughly around 24 gum like that. The main drawback behind the unsuccessful quitting in spite of giving the NRT is the inadequate dose. That is the important issue. That has to be keep in mind. But second thing about the procedure means how patients should take it. I mean, method of taking. Best method is chew and park method. That means patient have first initially to choose for sometimes, then we have to park under the lid. Then roughly it will continue one gum, it will continue about 30 minutes like that. But one important two things important, but avoid acidic beverage because nicotine is absorption is delay on acidic environment. That's why acidic beverage 15 minutes pre and during the dose of nicotine, we should avoid it like coffee, soda or juice like that. But one important study, it has been seen that there is probably no definite benefit if beyond 8 weeks, probably NRT may not work. This is all about the gum. About the patch, as I have told you, if a person is heavy smoker, means smoking more than 20 cigarettes a day, we should prefer 21 milligram of patch. And if a person is less than 20 cigarette per day, we should prefer 14 milligram of patch. It is a sustained release form. We have to apply it in the non-hairy part, so that because there is some side effect related to itching, and each day before going to the sleep, we should, the patient should remove the patch, so that some side effect, particularly insomnia, is more pronounced, particularly the say patch part. This is in a nutshell all about the NRT. Over to you, sir.
Very nice, Dr. Sudarsan Pothal. I think you will agree with me, in our actual practice, when you help and use the chewing gums, number of chewing gums to be used from 12, 10, 9, 8, and to be used every day at that much amount of chewing gums, patients usually do not cooperate. It is what is my experience, because the dose is very high, and they don't stick to, and then method of chewing, keep it under the gums, then once it is released, again chew it, again the nicotine should release, and it should take half an hour of the process. But I have found in my practice easy, the nicotine patches that are used, you apply it on the skin, leave it for 24 hours on the non-hairy area, and use it for 7 days, and reduce the strength to 14 and then to 7, and maintain on 7. That I have found being effective and more practical, rather than giving the patients the chewing gums, and usually they don't stick, and after a week or 10 days or 15 days, they discontinue on one or the other pretext. This is what I have, but I think
yes, you are right, sir. But one thing in patch basically is a sustained release form. It cannot relieve the acute craving situation. So that's why in acute craving situation, the only option left is for us is chewing gum.
Right. Thank you, sir. Now coming to the drugs, Amithash, we have bupropion, we have vernicillin. Which you will like to use, and which one is better?
These are the two drugs which have been in the pharmacotherapy of smoking cessation with regard to anti-craving medication. So they basically cut down the reinforcing or pleasurable effects of the nicotine. Whenever the patient selects for the quit date, ideally 5 to 7 days prior to this quit date, the patients have to start these medicines. I would like to first take up with probably a little bit better quit rates which have been seen in studies like varenicline, but it is not easily available and little bit costly. So it's a partial agonist of the alpha 4 and beta 2 adrenergic receptors with regard to nicotine, where the nicotine usually acts. So by taking up this receptor, this varenicline usually acts as an anti-craving medication. And there is one important study which I would like to quote here called the Eagles trial, evaluating adverse events in global smoking cessation study, which was a double-blind RCT, which involved more than 8,000 smokers, where they tested vernicillin, bupropion, nicotine patch versus placebo. Each of these were effective compared to placebo over the study period. But one thing we did not cover is the combination nicotine reduction therapies. Like usually, whenever we in practice, we give patch and we also give small dose of short-acting nicotine therapies like chewing gum and all. So it was not compared with the combination therapy. So varenicline favored as a higher quit rates compared to the long-acting nicotine patch and the bupropion. So it is usually given in a dose of 0.5 mg OD for first 3 days, then raised up to 0.5 mg BD. Then over a period of time, it is increased to 1 mg. They tell in clinical practice, like it has a lot of intolerable nausea and vomiting side effects. So whenever the patient is given in the titrating dose, it gets adjusted. Initially, when it came into market, it has a lot of FDA advisories like neuropsychiatric events, cardiovascular events. But over a period of time, some studies did not show any significant changes. And whenever it is used in some of the trials as a smoking cessation, it did not show. But one thing which is cautionary is the patient may have some suicidal tendencies. So patient who are psychotic and all, better not to prescribe this medicine, varenicline. The next competitor with regard to the pharmacotherapy is bupropion, which is a dopamine and norepinephrine reuptake inhibitor. This drug, which is most commonly available, and most of the clinical psychologists and psychiatrists have very good experience giving this bupropion as a atypical antidepressant medicines. So they are good with the practice of this medicine, which is usually started as 150 mg OD for 3 days, then increased up to 150 mg BD for 7 to 12 weeks. Usual duration is 7 to 12 weeks for most. And with the same practice of varenicline, around 5 to 7 days before the quit date, we have to start this bupropion. Both these medicines have some agitation, restlessness, insomnia, and all. But the bupropion has some tendency to cause increased seizures. So whenever the patient has uncontrolled seizure, this is quite contraindicated. Both these medicines should not be given in pregnant women. So strictly no pharmacotherapy of bupropion, varenicline in pregnant women as well. So if you ask me if the patient, based on the patient resources easily available at local setting, based on the patient preferences, I think both of these drugs may feel good. If he has underlying depression as well, bupropion fares well than varenicline. If we don't want to get that post-cessation weight gain, bupropion again has some weight loss things. It can help him in cutting this weight gain. So it all based on the local resources which are available, sir. Over to you.
So very nicely talked, Dr. Amithash, about bupropion. Another important thing is it's very clear it's 150 milligram OD for 3 days and then twice a day for 12 weeks to go. Patient with seizures, it should not be, and it causes seizures, and it should be swallowed. It should not be chewed as a whole. Do not chew or crush or divide bupropion tablet, and it should not be used for hospitalized patient with acute MI. This is what I will like to add, and you will agree with me. And varenicline, yes, it is not available so freely. 0.5 milligram OD for 3 days, and then 5 milligram BD for 4 days, and then 1 milligram OD for rest of the 12 weeks. Why I am repeating it is the two people who are asking the same question, Dr. Jitendra Kumar Dhyalal Shah from Gujarat and Dr. Asim from Kamptee, Maharashtra. So I think we are able to answer both these doctors' questions in our discussion. Thank you for joining us, Dr. Jitendra Kumar, on behalf of CCI. And we have discussed with you the side effects of these drugs. And you can write in chat box if you want any other opinion. Now, transforming this from pharmacotherapy to the recent version, Dr. Sudarsan, for the e-cigarettes, and where you keep them for smoking cessation.
Yes, nowadays, of course, very discussion about the e-cigarette. Basically, the e-cigarette contain 3 parts. One is a battery, and second is liquid content cartridge that contain nicotine. Roughly around that, if you say that nicotine for the main substance for the addiction, definitely e-cigarette contain the nicotine, except other toxic material other than cigarette. That means nicotine is good, but problem here in e-cigarette is that the main concern about whatever the study based on frequent since last 10 years, many randomized control and also review articles with systemic review and meta-analysis. There is a mixed impact. I mean to say, some studies point that yes, electronic cigarette, e-cigarette having benefit as regard to quitting is concerned. Been recently also 2021 a Cochrane database, they have shown that e-cigarette moderately certainly evidence that e-cigarette with nicotine increase the quit rate compared to e-cigarette without a nicotine, and also compared to NRT. But problem due to e-cigarette is due to the solvent. Means one of the important like say, as you have Dr. Chawla already explained previously about the 2 component glycerin and propylene glycol, which is an important, again, is carcinogenic. Some additive flavor also added in e-cigarette, that is also concerned for toxic of lungs too, and so too. That's why at present, yes, there is evidence in favoring towards the success of smoking cessation by use of e-cigarette, but this evidence at present is not sufficient to recommend e-cigarette as a smoking cessation method. Over to you, sir.
Very nicely explained. You cannot advocate, as we have already enumerated as per the American Association. Also, there is not enough evidence that e-cigarettes help you in smoking cessation. There is a question by Dr. Aruna DS from Karnataka, Bangalore. Diacetyl compound in e-liquids and lung injuries. We know it is well established that it leads to ARDS. And as I've told you, there was a time when in a study where so many young people suffered from lung injury and there were so many casualties, those who were using the e-cigarette, it was because of diacetyl compound in the e-liquids. Now, again, coming back to Manjula with his interesting approach, what is the role of motivational interview, Dr. Manjula? We have heard, we'd like you to enlighten us.
Thank you, sir. So coming to motivational interview, it is one of the types of counseling methods we have. We have many kinds of counseling processes, which is also called psychotherapy. So motivational interviewing, henceforth I'll be calling it as MI, is one of the methods. So in simple language to define MI would be, it's a conversation of change. It is a conversation between a therapist and the patient, or doctor and the patient, where the patient is motivated to change. So in this motivation, it is evoked from the patient. The doctor doesn't involve in any kind of advice giving or assessing the patient. This has to be remembered. Now, this is very effective because it's an evidence-based practice. And there are more than 1,500 papers published in MI, the efficacy of MI, in many different journals. Okay, so the question comes, why is it hard for the person to change? Like we have already discussed in the trans-theoretical model of change, the stages of change, that when they are in PC stage, pre-contemplation and contemplation stage, only then we use this motivation interviewing. Otherwise, it is not needed. The person is well motivated and he's compliant with the treatment. Now, here the question comes, why is the person not motivated to change? Is it because he doesn't have enough information? Is it because he's lazy or he's an oppositional person, etc.? It is not because of that. It is because of ambivalence. That is, the person is unable to handle that anxiety and he's not sure. It is mainly because he's unable to tolerate that uncertainty. Will I be able to quit or will I not be able to quit? And if I quit, how will I manage the anxiety? What is the other method that I will be using? Will my family members support me or no? Or will my family members discourage me, or will they be with me if I go back to smoking? All these things make the patient very, very anxious. And due to this ambivalence, he remains in the same situation, in the smoking situation. Now, how do we resolve this issue? So for this, I would be giving you two acronyms. And you will have to imagine a situation in this so that you remember better, because we don't have a PPT. So I just want you to remember this. For this, you have to imagine that you are traveling in a boat with this patient. Okay. So you are in a boat, the doctor and the patient, and you are going at a certain pace, PACE. The P stands for partnership. So you can motivate the person only when the person feels equal to you. Like this is a collaborative effort where your conversation, the conversation that both of you are having, is non-judgmental. You are not assessing the patient there. You're not giving any label to the patient, and you're engaging in the patient completely as an equal partner to him or her. Okay. And there is no disengagement. What is disengagement? It's the opposite of engagement. In disengagement, there is advice giving. Suppose the patient says, you ask a question, how many cigarettes do you smoke a day? And he says 20. So it is part of your training, and it is human nature to show concern and protect the patient, protect another human being. So we said, oh, that's very bad for you, you should not be smoking so many cigarettes. So this advice giving actually shuts off the communication, and you become greater than the patient, and there's no partnership. So you should remember to be completely engaged and not to disengage by assessing the patient, or saying, okay, you have addiction, you are addicted, you are dependent. By refraining from all these phrases, then there is a good partnership. Now you have set the stage. This is the process to begin. And in PACE, A stands for acceptance. So there are many theories why people smoke. So there is one theory which can neither be denied nor, approved. That is the theory, the Freudian theory, the theory of Sigmund Freud, who says smoking is the outcome of, negligence in the oral fixation stage. That is when the mother had to breastfeed the child. She was either very busy person, or for cosmetic reasons she hasn't done, or she had a baby very quickly, so this child was neglected. So that this person grows up and gets into smoking. So we don't know if it is true. We cannot deny this theory nor accept it. So according to that, if we see, yes, there has been no acceptance. So here, as a doctor, there should be complete acceptance. Again, there should not be any judgment, no assessment, and no advice giving here. And C, in PACE, C stands for compassion. You just have to look at that person like another human being who is suffering from a different problem. All human beings have suffering, and pain is common to all suffering. Only thing, in different flavors we suffer. And this we need to have constantly as we are sitting in the boat with our patient. And E stands for evoking. So whatever methods, whatever advice you want to give, everything should be elicited from the patient. Suppose he says, I am planning to change. So you will ask me, okay, what makes you to change? Or give him a Likert scale and say, on a scale of 0 to 10, how much do you want to change? If he says 6, then ask him, why not a 4? Why not a 2? So this way you will evoke it. So in the boat, you are following a certain PACE, P-A-C-E. This is the acronym. Now, what are the tools you need in the boat? You need oars. Oars is that stick with which we row the boat. So what does oars stand for? So these are the tools you use in motivational interviewing. O stands for open-ended questions. Like you cannot ask a question which gives yes or no answer, and afterwards there is no scope of conversation at all. Like, are you fine? So he'll say, yes, I'm fine. Instead of that, tell me how you're feeling. Or, open-ended questions where you can extract more information. Or tell me what makes you to change, or tell me what made you take this decision, that way. After open-ended questions, oars, the second letter is A. A stands for affirmations. You have to listen carefully. Whenever there is something good in the conversation, you have to affirm it also. Like, I'm planning to change because of my family. So you will have to affirm that you are thinking of your family. You have put a great importance to your family life. So this helps the person to, boost him up. It encourages him when we point out to the good things in the conversation. After A comes R. R is nothing but reflection. Reflection is his own statements. You will be reflecting, so that you help him listen to his own motivational statements. Like if he says, I want to change. I want to quit my smoking. So you say, so you're thinking of changing. So you're just putting it in another way, which will motivate him further. And the last letter in ORS is S. S is nothing but summarizing, which is a long reflection. Sometimes patients put us in a confusing state, like they say positive and negative things. Like, I'm planning to quit smoking, but I don't know what to say to my friends when they call me for that break when we smoke. And at the same time, I'm worried about my health. Now we get frustrated, we get burnt out with these kind of conversations, because one time they are saying I want to quit, then again they present another problem saying that my friends may call me, I don't know what to say at that time. So we are forced to, they pull us into advice giving. No, you can tell your friends not to call you, etc. No, it is not our job. What we do here is we just summarize the statement. I see that you want to change, but there is a drawback in this, that is, your friends are trying to call you and you're finding it hard to refuse them. But you're also saying that your health is important. Tell me which one you think is more important and where you can be assertive. So, this way, we are throwing it back, the responsibility on his own shoulders. And then he tells us what are his methods of change. That way we can evoke. So, these tools have to be used interchangeably, and you can use all the four tools together, sometimes just one tool at a time. But remember to keep these tools handy and never give in to advice giving or assessing or labeling him. That will stop off the conversation and motivation does not happen. Thank you, sir. Over to you. Say you're on mute.
Manjula, thank you very much. Your bow should have all kind of arrows. Whatever when required should be used. And I am convinced that you have to be part of the pulmonary tobacco cessation clinics. Aruna is there. I'll quickly finish before asking the questions, because Aruna from Bangalore, protective factors for tobacco cessation, we have discussed. There is an opinion of Dr. Meena Hingorani from Maharashtra, Vashi, Navi Mumbai. Instead of ban, reduce demand. When there is no demand, supply automatically will reduce. Agree with your suggestion? Dr. Aruna, again, nicotine as a gateway for future substance and behavior dependence. We know, but the amount used in nicotine replacement therapy is not that it is going to make you dependent for it. Dr. Ajay Lanjevar from Maharashtra, Nagpur, initiatives from NGOs, political will to change the workforce to shift to another, I think we have discussed. Dr. Kripa Shankar Khare from Uttar Pradesh, Lucknow. My suggestion, make availability of cigarettes at third or fourth floor of the market instead of availability on roadside. Okay, this is one of the very good suggestions, I believe. Dinesh Rawat from Uttar Pradesh, Ghaziabad. While quitting, man gets anxious, constipation, insomnia, loss of appetite. What medicine is preferred? See, as I suggested, the will has to be there. The psychologist has to be taken help. It's a multimodality approach, which is going to be discussed once I finish answering these questions, because all of you are looking for your answers. Yes, this happens, and this is what is all about smoking cessation. Ajay Lanjavar from Maharashtra, Nagpur. This question I have already read. Dr. Kripa Shankar Khare, I have read. Yes, Dr. Dinesh Saraswat. Again, Ajay from Maharashtra. So we generate good income and at the same time we lose at another end. Yes, one has to think about it, whether this is a money which is worth it at the cost of our patients. Dr. Ramesh Meena, New Delhi. What is the pharmacotherapy for quit smoking? We have discussed in details by Amithash, the bupropion and vernaculine, their dosages, their side effects, how they are used, how they should be taken. And in detail, Dr. Sudarsan has told about the chewing gums, how they should be used and how the patches should be used. Again, Dr. Aruna, assertive Training, yes. Various tools as described by Dr. Manjula beautifully. I am going to tell you that this is a new armamentorium in our pocket today. Dr. Asim Kanti Bera, West Bengal, select if cocaine, cannabis could be banned, why not nicotine? Yes, this is a thought-provoking question, and I agree with you. We are not, Dr. Ajay Lanjevar, we are not learning from our mistakes and working on effective measures. My dear, I agree with you, since it's a political will which has to be there, and we have to restrict our comments on this. Dr. Aruna, again, Varnasilin is retracted from the market since June 21. Yes, because of their side effects. Shashikant Gajare, Maharashtra, Jalgaon. What is the reason nothing happens in some chain smoker individuals? Well, my dear, five fingers are not same. You will see the people smoking at the age of 80 and 90, nothing happens. But don't take it for granted. The young people suffering from lung cancer as direct cause of smoking. So they cannot be set as an example. So all five fingers are not same. You are absolutely right, but it is well established the smoke is a direct cause of lung cancer and crippling lung disease like COPD. Dr. Zakir Hussain, Telangana, Hyderabad, how many days maximum we can advise nicotine patch? It is a 21 days course you are using in reducing order from 21 milligram to 14 milligram to 7 milligram, and we can maintain it, and you can use it maybe for a month, say for 4 weeks, and the patient is helped to stop smoking. It is his will with the clinical psychologist help that you can maintain him that he should not smoke. Dr. Bhuvneshwari, Gujarat, Baruch, please explain in details how and in what dose to prescribe medicines for smoking cessation apart from the nicotine. We have already discussed Bhuvneshwari in details about bupropion and Varnasilin. Bupropion is 150 milligram to be taken swallowed, not to be chewed. It is used OD for 3 days and then BD for 12 weeks. And Varnasilin is 0.5 milligram OD for 3 days and increased to BD for 4 days and then 1 milligram OD for rest of the 12 weeks. Again, Asim from Maharashtra, is there a difference in toxicity of cigarettes or BDs? No, there is no difference. And let me tell you honestly, the BDs are more dangerous than cigarettes. Again, there are RCTs and trials which prove beyond doubt that BDs are more dangerous than this. Meena Hingorani from Maharashtra seems to connect. Okay, have not been able to hear completely. Please repeat this advice from Dr. Manjula. I cannot, because see, it's a topic which she has discussed from her heart, and I am very happy that the clinical psychologist was with us. I think I have answered most of the questions, and we have already told about role of multimodality approach. And before closing, the Government of India policy is the Government of India has banned e-cigarettes in the country. That is one of the wonderful news what we have got. So my co-panelists, Dr. Manjula, Dr. Sudarshan, Dr. Amithash, they want to say any closing remarks. Please, Dr. Amithash, what is your closing remarks to the smoking cessation webinar today from CCI?
It's never late to quit smoking, sir. So whenever they decide the smoking habits, it's never late to quit the smoking. So if you decide today, quit today itself, you will be having some health benefits of smoking cessation. The earlier you quit, the better it is for you. And you have a lot of support, like psychologist supports and all, which are easily available and easily acceptable. Just before the start of this webinar, I was just speaking to Dr. Manjula ma'am regarding the psychological sessions during COVID pandemic, and she has done some beautiful work. If you have some psychological support like her in the nearby town, I think it should not be a difficult task to quit smoking. So if you could convert at least one person today because of this webinar, any of our patients or relatives to quit smoking, our purpose is served. Thank you, sir. Thank you very much.
Very nice, Amithash. Sudarshan, sir.
Yes, basically, willpower is most important part of whatever you already explained. And number two is about multimodal treatment. Based on different study, it has been seen that not only psychotherapy with say drug with NRT therapy will impact, will affect more, means success rate will be more. That's why both three angle we have to thought of both psychotherapy or behavioral therapy with nicotine replacement therapy as well as drugs. If three modality will combine, definitely success rate will be more. This is all about smoking cessation. Over to you, sir. Thank you so much.
Thank you, Dr. Sudarsan. So you agree in total it has to be a multimodality approach to help in stop smoking. So our lady power, Dr. Manjula Rao, for final take-home message.
Thank you so much, sir, for the inclusion. That, of course, this is a new stage in our country. Even today, people feel the stigma to walk up to a psychologist because nobody wants to, come and show that they are broken or damaged and you need another human being to fix it. But that should not be there, because we are all, as fellow human beings, we are here to help each other. And thank you so much for including us. And now the mental health bills have come up since 2019. And after COVID, after the pandemic, yes, psychologists, our work is being recognized. And thank you for including us. And definitely multimodality treatment has better outcomes, clinical outcomes, and the patient outcomes than, a single modality treatment. Thank you once again, sir. And thank you to all the doctors.
Thank you, Dr. Manjula. Let me happily announce to tell you, total login today is 1108. And I hope we have done a justified webinar with my co-panelists, Dr. Amithash, Dr. Sudarsan, Dr. Manjula Rao. I'm thankful to all. I'm thankful to CCI, where equality for all is the motto. And this is what is the platform and theme of CCI. Thank you very much. I think we take leave now. And thank you very much. Thank you, sir.
Thank you. Thank you. Thank you to everybody.
Thank you, sir.